growing treatment burden was a concern. In Yorkshire, in north of England, we felt that doctors or our allied health professionals were not considering steroid in the right group of patients. So we devised this guideline. And essentially, you give them anti-VEGF as the first line. The only time I wouldn't consider first-line anti-VEGF is if you have a pseudophakic patient or a patient with a cardiovascular event, or they can't cope with the regular reviews and the injection frequency required of anti-VEGF. I might go for Ozurdex first line or a steroid first line. But most of the time, I go for anti-VEGF first line. And if you give them 6 injections at least as a minimum, as a maximum, but I tend to make the decision at 3 to 4. But we allowed for some flexibility, and we said a maximum of 6 monthly injections. If they got less than a 20% reduction in their central retinal thickness or less than a 5-letter gain in vision, this was defined as an insufficient anti-VEGF response, and we considered corticosteroid. All other patients could continue on anti-VEGF if they responded well, but at year 2, at the end of year 2, we looked at the previous year, and if the patient needed more than 6 injections in that year, then you could argue introducing corticosteroid to reduce the injection burden for that patient. This is a patient who requires anti-VEGF very frequently. Could we use corticosteroid to give them the efficacy, stabilize the edema, but reduce the burden of injections? This is a case report from where I used to work in Sheffield. So this patient attended to me by accident, completely by accident. She was actually being managed by another attending consultant. It was a 72-year-old, pseudophakic, diagnosed with center-involving edema, and baseline vision was 624 with a thickened macula. This was her OCT. And this is the visual acuity over time. So as you can see, she was not under my care, she was under one of my colleagues. They'd proceeded with 18 Lucentis injections, followed by 6 Eylea injections, and not one person in the team considered an alternative treatment option. The patient's vision was not improving, the macular thickness was not improving, yet they continued with anti-VEGF. I saw her completely by accident, recognized that this patient was having an insufficient anti-VEGF response. I gave her an Ozurdex, and the vision improved to 624. This is the same graph, but looking at the macular thickness. Can you skip a slide for me? There we go. And as you can see, the edema is not really improving, or if it's improving, it's a suboptimal response. And they've given her 24 injections before anybody's considered an alternative treatment approach. I gave her an Ozurdex injection, and her macular edema decreased from 600 to 300 microns. This was her OCT at month 17, marked diabetic macular edema despite regular anti-VEGF injections. I gave her an Ozurdex with a swift improvement in the macular edema, but unfortunately the vision didn't recover. And that's because we made the treatment decision too late. We made the switch too late. And if there's one message I'd like to give you all is, by all means, use anti-VEGF first line, but after the 3rd to 4th injection, if it's not making an improvement in that patient's vision, if you're not restoring the macular anatomy, consider switching. And I would recommend corticosteroid as a good option in this group of patients. Less than 5-letter gain in vision, less than a 20% reduction in central retinal thickness, because you can be confident that the inflammatory pathway is mediating the breakdown of the blood retinal barrier, so they're going to respond very well to corticosteroid. How are we doing for time? So we're doing well? Yeah, we're doing well. So we're just going to switch my attention to another way I use Ozurdex in my practice back in the UK. So often when you do cataract surgery in patients with diabetic macular edema that require intravitreal therapy or anti-VEGF to control their diabetic macular edema, a concern of mine was that if I did the cataract surgery alone, there'd be an exacerbation of their diabetic macular edema with vision impairment, essentially spoiling my very good cataract or uncomplicated cataract operation. So I was always very keen to give a steroid at the conclusion of surgery. Initially it was triamcinolone, but then when Ozurdex was licensed in the UK for diabetic macular edema, I was giving Ozurdex at the conclusion of surgery. You don't have to do that. There isn't, some centers in the UK would do it prior to cataract surgery or within a couple of weeks from cataract surgery. But in Sheffield, we were such a busy department, I didn't have that flexibility, so I'd always give it at the conclusion of surgery with the aim of getting rapid improvement in vision, preventing macular edema exacerbation, and preventing the need of giving rescue intravitreal therapy in the 6 months after cataract surgery. And this is an audit of my results. Can you skip next slide? Again. So these were the baseline characteristics. So both had low vision and both had thickened macula. So both had diabetic macular edema at the time of cataract surgery. Next slide. And this was the change in central foveal thickness over time. So obviously, if you just did cataract surgery alone and just treated them with topical treatment, you're not going to make any tangible difference to their macular thickness. And remember, this cataract-only group were getting rescue anti-VEGF injections after cataract surgery. But in the steroid prophylaxis group, who got either triamcinolone or Ozurdex at the conclusion of surgery, there's an improvement in the central foveal thickness that's kind of maintained for 3 to 4 months, and then it kind of reverts back to its baseline, which fits with the pharmacokinetics of triamcinolone or Ozurdex. And if you look at the best recorded visual acuity, there's a rapid improvement in vision that's kind of maintained over time, and it's superior to the cataract-only group. So the cataract-only group did well, but they were needing lots of anti-VEGF after the surgery to maintain that vision gain. In terms of what were the mean number of additional anti-VEGF injections, if you did cataract surgery alone, on average they needed 1.4 injections over the following 6 months. But this ranged anything between no injections to 4 injections. As for the steroid prophylaxis group, on average they needed a half injection over the 6 months, and the range was between 0 to 1, with 63% of the steroid group requiring 0 injections in the 6 months after cataract surgery, purely because I gave a steroid, an Ozurdex, at the conclusion of surgery. What was interesting is if they needed intravitreal therapy in the lead up to surgery, cataract surgery, as in within the 6 months leading up to cataract surgery, the risk of needing an injection was 75% if you did cataract surgery alone. So in the end, you're kidding yourself. If you do cataract surgery in a diabetic where you're treating their macular edema with intravitreal therapy, if you do not give prophylaxis, their edema is going to exacerbate and you will give a rescue injection. So in conclusion, patients with recently treated diabetic macular edema with intravitreal therapy within 6 months of the planned surgery would benefit from prophylactic effect of an intravitreal steroid at the conclusion of cataract surgery, but you could modify that by doing it prior to surgery or 2 to 3 weeks after surgery. There is this theoretical risk of when you do it at the same time that you might increase the risk of endophthalmitis. But none of my cases have ever developed, alhamdulillah, endophthalmitis. And I treated around about 100 eyes in the UK. The main reason why I did it, because it represented a cost saving. By giving the Ozurdex, I was giving fewer rescue anti-VEGF injections. I had to bring the patient less frequently to my very busy NHS clinic. And lastly, intravitreal steroid cover following cataract surgery in eyes with recently treated diabetic macular edema appears to be an effective approach, and I recommend it as a treatment option. Thank you ever so much.
Thank you very much, Fahd. That's really a nice presentation. And let me go through a few questions with you regarding what you presented here. Okay, I can understand if you mentioned the guidelines, what I mean, the European guidelines for when to use steroids as first choice. What I'm saying for non-compliance patients or those who had stroke or whatever, and pseudophakic as well. But do you agree with me there is other two indication, in my opinion, which has not been added to these guidelines, which is vitrectomized eye, because simply in diabetic patients who do a lot of vitrectomy for vitreous hemorrhage, peripheral diabetic retinopathy, whatever. And in this case, vitrectomized eye will not be the good harbor for short-acting anti-VEGF because they will wash quickly. In this case, steroid implants can consider as a first line. The second case, definitely, that I'll add it to this, pregnancy. In pregnancy with diabetic macular edema, this patient will not be able to have anti-VEGF because simply it is contraindicated because of the baby. So in these two cases, please add it to the list, and you can use the steroid as first line of treatment.
Actually, no, thank you for those additions. Vitrectomized eyes and pregnant patients, you think you won't find them, but they are common enough. And I think, the design of Ozurdex ideally fits for those patients, but for the pregnant patient, it's been shown to be very safe, giving intravitreal steroid, without any harm to the unborn child. And I'm sure everyone in the room is aware it's a contraindication giving anti-VEGF in anybody who is pregnant.
Great. The other thing, I liked your study when you said we will give Ozurdex by the end of cataract surgery, because we're doing cataract surgery in diabetic macular edema patients. But anyone can argue if you had a third arm where you can give Lucentis injection or Eylea injection, during the surgery or before the surgery or after the surgery, that's what we missed in your study.
Well, it's interesting. Yeah. I did do that study where we were giving Lucentis at the conclusion, and quite reasonably or quite not surprisingly, steroid gave you a better outcome. And it's purely because cataract surgery is inflammatory, you're giving steroid, you're suppressing all the mediators. It's not, certainly for the context of cataract surgery, I would always prefer a supplemental steroid over a supplemental VEGF injection.
Maybe I'll agree with you on this point for one reason, because even cataract surgery itself, it's a traumatic surgery, and you will never know whether the edema after the cataract is coming because he's diabetic or because it is post-surgical. So in this case, steroid could work for both compared to the anti-VEGF. Let me say something else as well, okay? Now we used to use steroids as a second choice, and we say there is some indication to use as first choice. However, with the new players coming, what I mean, there is two other anti-VEGF in the market now, PureView and Faricimab, and we can use them for diabetic macular edema. Do you think the